Formation of urine. The filter production occurs within the renal corpuscle. The passive separation of water and solids from the blood plasma within the glomerular capillaries is also known as glomerular filtration. The filtration membrane is this porous, thin, negatively charged membrane that forms two layers of glomerulus, the visceral layer, also referred to as a filtration membrane, and the endothelium of the glomerulus, which is fenestrated, allowing plasma and dissolved substances to be filtered, while restricting passage of larger structures like the blood cells and foreign elements. There's also going to be a basement membrane of the glomerulus, which is a porous membrane that restricts larger proteins, while allowing smaller proteins to pass through. This visceral layer of the glomerular capsule is composed of a cell called the podocytes. These are called foot cells. They contain these pedicels that help support the capillary walls and are separated by a thin space called the filtration slits. These cells are positioned within the capillary loops of the glomerulus, and so they have the ability to be contractile and phagocytic. Some of the key functions include they form the extracellular matrix and functions as a structural component to maintain the structure of this glomerular capsule and this filter. It also releases certain kinds of growth hormones for the maintenance of these capillaries. It also releases molecules that can mediate inflammation. And of course, there's also phagocytic activity when they can degrade unwanted substances. Filtration is driven by pressure. The difference between the blood's hydrostatic pressure within the glomerulus and the opposing pressures of both the osmotic blood pressure and the fluid pressure within the capsular space of the renal corpuscle is also known as net filtration pressure, also known as NFP. There are several pressures that come into this picture before the NFP gets generated. Blood pressure within the glomerulus that pushes water and some dissolved solids out of the glomerulus and into this capsular space is referred to as the hydrostatic pressure. So we have the glomerular blood hydrostatic pressure, and we also have the capsular hydrostatic pressure. These two pressures are shown in the picture, one in orange and one below it underneath as green. There's also going to be an osmotic pressure exerted by the blood due to the dissolved solids contained within it. Most notably the plasma proteins or colloids, and hence the name blood colloid osmotic pressure. This pressure tends to draw fluid into the glomerulus. So the pressure within the glomerular capsule is due to the amount of filter within the capsular space, which is going to be your hydrostatic pressure in the capsular space. And this pressure impedes the movement of additional fluid from the blood into the capsular space. So NFP, or net filtration pressure, you have to be equal to the blood colloid osmotic pressure plus the capsular hydrostatic pressure minus the glomerular blood hydrostatic pressure. So it would be BCOP plus CHP subtracted from the GBHP would be equal to the NF. So plugging these numbers in, you would get 55 minus, which is equal to 10. Regulation of this glomerular filtration rate. The kidney controls GFR and thus controls the urine production based on the physiological conditions such as hydration. GFR is primarily influenced by the changing diameter of our afferent arteriole and by altering the surface area of that filtration membrane. Glomerular filtration is influenced by the processes of intrinsic control, which consists of renal autoregulation and also extrinsic control that is controlled by hormones and neurotransmitters. So let's talk a little bit about the renal autoregulation. The intrinsic ability for a kidney to maintain a constant blood pressure and constant GFR, despite changes inside the systemic arterial pressure, is called renal autoregulation. The mechanism involving contraction and relaxation of the smooth muscle wall of the afferent arteriole is then referred to as a process in this called the myogenic mechanism. So a decrease in the systemic blood pressure will cause the blood pressure entering into the afferent arteriole. So therefore, what this means is that when you decrease the systemic blood pressure from the heart, you're going to decrease the amount of blood that gets to go into the afferent arteriole. And thus, a reduction in the arterial wall, stretch followed by the vessels relaxing and dilating, allowing more blood to entering, compensating for that lower systemic blood pressure. So you can see right here, then this afferent arteriole will dilate. Dilate will then increase more blood flow, increasing NFP, and therefore boosting up GFR. Another way you can control this is by constricting the efferent arteriole. If you were to constrict the arteriole, you would trap more blood inside the glomerular capsule, therefore also creating a situation where you increase GFR. On the other side, let's say you have too much blood, then you can cause a constriction at the afferent arteriole that will then reduce the amount of blood coming in, therefore the blood amount over here will drop down, and hence NFP will go down and GFR will go down. Likewise, if you were to dilate the afferent arteriole, dropping and reducing the NFP, and therefore also reducing GFR. So the magnitude of the NFP is directly proportional to the GFR. So just remember that when you increase the systemic blood pressure, which will cause additional blood volume to enter in the afferent arteriole, you want to protect your kidneys. Therefore, stretching the arterial wall will lead to vasoconstriction, and then the afferent arteriole will allow less blood to enter in, protecting it from any kind of damage by pressure. This compensates for higher blood pressure. Right-hand side is if you were to have low blood pressure, and then the left-hand side is if you were to have high blood pressure. Measuring renal plasma clearance. There's a test that can measure the volume of blood plasma that can completely be cleared of a substance in a given period of time. And this is referred to as a renal plasma clearance test. The renal plasma clearance test enables one to infer whether or not one substance is reabsorbed or secreted. A substance that is neither reabsorbed nor filtered has a renal clearance equal to the GFR. And this is a great way to approximate the GFR. The equation is as follows. You have the concentration of whatever substance inside the urine multiplied by the rate of urine formation divided by the P, which is the concentration of substance in the blood plasma. And that will give you C, the clearance of that compound, typically expressed in milliliters per minute. But many medications out there exhibit renal plasma clearances that are higher than GFR. So therefore, if a substance is neither reabsorbed or filtered, then the renal plasma clearance would be equal to the GFR. However, if a substance is reabsorbed and has a plasma clearance that is lower than GFR, however, if a substance is reabsorbed, it's going to have a renal plasma clearance lower. So therefore, you can say that if clearance is equal to the GFR, that means the compound or substance is not reabsorbed or filtered, and this will happen. But if a substance is reabsorbed, then that means the renal plasma clearance will be lower than that of the GFR. In many medications, there's also going to be a situation where the clearance is much higher than GFR because they're secreted, and hence the importance for the renal plasma clearance is to be determined prior to giving the right amount of dosage. So a lot of drugs, the clearance is actually greater than the GFR. Here's a list that shows you some of the key ions and what gets reabsorbed. Inside the proximal convoluted tubule, sodium is reabsorbed primarily by primary active transport. So there's a lot of sodium channels. Glucose, amino acids, proteins, and vitamins are then reabsorbed via secondary active transport, which means it requires sodium to hitchhike along the way. Bicarbonate, calcium, magnesium, phosphates, and potassium, these are also actively reabsorbed, as well as water and some other ions may passively follow via osmosis. As you transition down to the ascending-descending limbs, most of the remaining water, including sodium, chloride, and potassium, is then reabsorbed. However, there is a unique difference between the descending limb and the ascending limb. The descending limb is permeable to water, so water can go through. However, the ascending limb is not permeable to water, but permeable to solids. The nephron loop. A positive feedback mechanism occurs whereby the tubular fluid reverses direction as it moves through the descending and ascending limbs of the nephron loop. And because of that, it increases the salt concentration within the interstitial fluid. This is referred to as the countercurrent multiplier effect. So let's talk about the way this works. So over here, the descending limb is permeable to water, but impermeable to salt movement. As a result, water is able to move out to the tubular fluid, but the salt gets trapped inside this tube. And then when you go to the ascending limb, this region on the right, this is impermeable to water, so water gets trapped inside, but it actively pumps out salt to tubular fluid. So salts are pumped out, but water is now trapped. So the blood within the vasa recta, which is the blood vessels right next to it over here, it's actually right on it. So this process whereby the vasa recta helps maintain the concentration gradient through this converse directional flow within the parallel capillaries and exchanges of salt for water is also then the countercurrent exchange. So whatever water comes out of the descending limb gets to go right into the vasa recta, and whatever salt comes out of the ascending limb goes back right into the vasa recta. It should be noted there's also higher amounts of urea inside the medulla of the kidney. So the urea is then removed from the tubular fluid in the collecting duct and diffuses back into that thin segment of the ascending limb. As a result, urea is also trapped, increasing the water pull-out effect as well. So the recycled urea accounts for about 1/2 of all the solutes inside our interstitial fluid. Urea then remains within the tubular fluid until it reaches the collecting tubule, keeping the concentration extremely high at the base of the collecting duct.